Everybody, please rise. Announcing the arrival of Professor Datuk Dr. Adiba Kamaruzzaman, the Dean of Medicine of University of Malaya, and Professor Dr. Ahmad Hatim Sulaiman, Faculty of Psychological Medicine, University of Malaya.
Universiti Malaya, kebanggaan kita semua, bertambah para ilmuwan di pelbagai lapangan. Kami bertekad di hati mencapai cita murni, tradisi kecemerlangan menepati di sini kami sedia berbakti, terus berinovasi. Kami harapan generasi muda, teras nusa dan bangsa. Varsity kesayanganku, sungguh banyak jasamu membentuk insan mulia, berilmu berbudaya. Di sini kami sedia berbakti, terus berinovasi. Kami harapan generasi muda, teras nusa dan bangsa. Varsity kesayanganku, sungguh banyak jasamu membentuk insan mulia, berilmu berbudaya.
Professor Datuk Dr. Adiba Kamaruzzaman, the Dean of Faculty of Medicine, University Malaya. Dr. Hazli Zakaria, Head of Malaysian Psychiatry Association. Mr. Wong Kin Sang, Country Manager of Lundbeck Malaysia. Mr. Sandeep Jamini, Country Manager of Laboratories Torrent. Ms. Elaine Tan, Head of Global Clinical Operations Johnson & Johnson Malaysia. Professor Dr. Ahmad Hatim Sulaiman, Heads of Departments, ladies and gentlemen. Welcome to this inaugural lecture by Professor Dr. Ahmad Hatim Sulaiman entitled Identifying and Treating Depression, Are We at Risk? Without further ado, I would like to invite Professor Datuk Dr. Adiba Kamaruzzaman to chair the lecture and introduce Professor Dr. Ahmad Hatim Sulaiman.
Assalamualaikum and good afternoon, everyone. We're here this afternoon to listen to Professor Hatim. For visitors or guests who are not from the university, this is the moment when someone who has been elevated to the professorship shares their experience and their research with the campus as well as the public at large. Although Hatim has been a professor for some time, today he's chosen to share his work on depression with the rest of us. We here at the faculty are very proud to have, I think, the largest number of clinicians who have gone on to pursue PhD amongst all the medical schools in the country, and I dare say probably even in comparison to many of the other schools in the region, with, I guess, the exception of the Yong Lin School of Medicine, or NUS, and Lee Kong Chian, the new NTU Medical School in Singapore. But Professor Hatim, who after graduating from did his clinical masters in psychiatry at is one of those that we have at the faculty who braved many years of clinical training and clinical specialist training to pursue a PhD, which is, in my mind, no mean feat. He has chosen to focus on psychopharmacology of schizophrenia, bipolar disorder and depression, and substance use disorder or drug addiction. Professor Hatim has actually been very, very busy, particularly with advancing new knowledge in new pharmacology in treatment of psychiatric disorders, and for that has been a recipient of several research grants and awards, and has served on many national and international scientific committees and advisory boards. He's also on several editorial boards of international journals of bipolar disorder, current drug targets, and the Malaysian Journal of Psychiatry. And of course, he has also served as a consultant and principal investigator for multiple national and international pharmaceutical companies, including clinical trials in psychopharmacology. For those of you who know Professor Hatim, I think he is, I dare say, the most unflappable consultant and that we have in the faculty. I think even in the midst of any psychiatric crisis, you can rely on Hatim to be calm and sensible, and will put everyone to diffuse any tension that you may have from any major crisis, including psychiatric crisis. So, Hatim, we're all looking forward to hearing your research and the advances in treatment of depression.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good evening. Yang dikasihi Ibunda Hajah Samihah binti Jabah dan Ayahanda Tuan Haji Sulaiman Abdul Majid. Yang berbahagia Datuk Profesor Dr. Adiba Kamruzaman, Dean Faculty of Medicine. Yang berbahagia Prof. Masnah Dahlui, Deputy Dean Faculty of Medicine. Mr. K.S. Wong, Country Manager for Lundberg, Mr. Sandeep, Country Manager for Torrent, Ms. Elaine Tan, Head for Global Clinical Operation for Johnson & Johnson, Ms. YZ, Manager from Sevier, and professors, Head of Departments, teachers, friends, students. Thank you very much, Prof. Adiba, for a very kind introduction. And thank you for agreeing to chair this session despite your very busy schedule. And thank you to all of you for coming to support me today. It's a great pleasure and honor to be here today. Initially, I'm very worried. I told my children, please come. I scared only 5 people will come for my, for my Syarahan Perdana. So that's why I call my children my family. And I've been giving lecture for the past 20 years in various sessions, stages. But this is the first time I'm giving a lecture in front of my parents and my siblings. So this is truly an inaugural lecture for me. So like Prof. Adiba said, I'm always calm, but today I'm a bit nervous because my parents are scrutinizing my presentation. I hope I get their approval afterwards. Okay, so I'll be talking about identifying and treating depression. Are you at risk? So why do I choose this topic? Actually, there's a lot of reasons. And one of the main reasons is that I want to probably inform about some of the misconception about mental illness, especially depression. Having depression or other mental illness is associated with a lot of stigma. People will not hesitate to admit they have hypertension or diabetes or arthritis. But if I ask how many of you are taking antidepressant, nobody will, or very few will dare to admit. This is because a lot of misconception and misunderstanding about mental illness. So the most common misunderstanding, especially among the Malays in Malaysia, is mental illness is associated with what they call charm, black magic, demons, spirit. I'm not sure whether you know saka or not. Saka is a form of inheritance. It's not that you inherit the money or house. That's very good inheritance. But among the Malays, some Malays believe that you inherit the demons. Kalau Melayu kata hantu raya. So when you inherit the saka, some of the manifestation is mental illness, symptoms of mental illness. Okay, another common misconception is that only the weak will, lemah semangat, lemah iman, those who are lazy, those who are poor, those who are retarded, only these people can get depression, or only these people can get mental illness. But this is totally wrong. In my next few slides, I will prove to you that this is not true. Another common misconception. Mental illness symptoms will recover by itself. So when people are depressed, people always advise, okay, just snap out of it, pull yourself together, you can get through. Imagine you have heart attack, go to NE and say, just snap out of it, pull yourself together. So mental illness is just like any other medical illness. That's why I showed this picture. I'm sure the younger ones will know this is Wolverine. Wolverine is a character from X-Men, Marvel. My children likes to watch movies, so I sometimes have to follow them. So one of the movies is X-Men. So this is a Marvel character. He have a superpower. One of the superpowers, besides having this adamantium claw, this long claw, his power is he have self-healing. He can recover from any injury and any disease. So unless you are mutants like Wolverine, then you need treatment for any kind of disease, including depression. Okay, these are all the famous people. Most are famous people, very rich, very talented, and yet they have depression. I'm sure all of you will know this, Dwayne "The Rock" Johnson. He's one of the Hollywood tough guys. According to the Forbes magazine, in 2018, he's the second highest paid actor in Hollywood. So last year itself, he got $250 million US. So he was the former World Wrestling Federation. My father likes to watch wrestling, so I also watch wrestling together with him. And despite being the Hollywood tough guy, he suffered depression before. In fact, his mother committed suicide when he was 17 years old. And with treatment now, he's very successful. Next is Robin Williams. Again, a very famous actor, very talented, funny guy, comedian. Always seems to be happy, acted in a lot of comedies, but in 2014, he shocked the world by committing suicide, and he had depression. J.K. Rowling, she's the highest paid author now in the world. Her net worth is about $1 billion US. She's the author for, I think most of you probably have heard Harry Potter series, the Fantastic Beasts and so on. And before she published the Harry Potter series, she was depressed, and with proper treatment, she's now the richest author in the world. Lady Gaga, probably not well known here. She just won 3 Grammy Awards recently, and she's the 5th highest paid female singer. And she admitted that she had depression, received treatment, and get well. This guy, Michael Phelps, he's the most talented or the best all-time swimmer in the world. Michael Phelps won 23 Olympic gold medal. 23 Olympic gold medal. He holds the record still. The second person who have won most gold medal in Olympics, only 7 gold medal. She's a gymnast. Michael Phelps is 23 over his career. Half of the country in the world never won Olympic gold medal, including Malaysia. Michael Phelps single-handedly won 23 gold medal. Despite having 23 gold medals and all the other accolades, he still struggled with depression. You can read about his writings about depression and how he deal with depression. Buzz Aldrin. I'm not sure whether you all know who's Buzz Aldrin. My children know who's Buzz Lightyear. You know Buzz Lightyear? The Toy Story. Yeah, Toy Story is a movie from Disney Pixar. Buzz Lightyear. So actually Buzz Lightyear was, the name is from Buzz Aldrin. Buzz Aldrin is the second person who walked the moon. You know Neil Armstrong, right? But nobody knows Buzz Aldrin. After coming back from the moon, all the stress and tension, he developed depression, because everybody is praising Neil Armstrong and forget about him. People knows more Buzz Lightyear than Buzz Aldrin, But with treatment now, he's okay. Vincent van Gogh, very talented Dutch painter, was reported also to have probably depression as well, but this is in the 18th century. And finally, Abraham Lincoln. He's the 16th president in the United States. If you read some of the literature and political sciences, he's probably the best US president among the 44 presidents in US. Definitely better than the current US president. But despite all the history of depression, he made to be one of the best presidents in the United States or probably in the world. So depression is not affecting the weak. And if you have depression, doesn't mean your life will be ruined forever. But the important thing is that you must come for treatment. Okay. So depression is on the rise in Malaysia as well. This is the National Mobility Study. So the prevalence of mental health problems among adults in Malaysia has increased from 10% in 1996 to 11.2% in 2006 to astounding 29.2% in 2015. And depression will be a major mental health illness Malaysia suffers by 2020. At UMMC, we are the busiest psychiatric unit. We even have more outpatient than each KL because we have what we call a walk-in clinic. On average, we see about 2,700 to 2,800 outpatient a month, or about 34,000 patients visit a year. And out of this, about 160 are new cases. And if you ask my MO who runs the walk-in clinic, more than half of them are depressed. Hopefully the MOs are not depressed. But half of the patients who come to the clinic every day are having depression. And this is a primary care studies done among patients visit to primary care. Primary care means outpatient hospital unit. So the prevalence of patients presenting to hospital is estimated to be about 14 to 18%. So this is 1 in 7. Every 1 in 7 patient who comes to the hospital, most likely they are having depression, and especially more in elderly. So this is the study that we did last year. So I like to thank especially the main author, which is Dr. Benedict Francis. He's not here. He's having attachment in Melbourne doing geriatric psychiatry. and also my classmate, Dr. Justice Singh. He's my classmate since medical school. And of course, other authors is Dr. Fatin, Dr. Zuraida, my other classmate, Dr. Mas Ayu, Prof. Ko, and Prof. Ng Chong Guan. So what we did is that we get, of course, with the Dean's approval, we survey 622 medical students from year 1 to year 5. This is 89% responders. There are about 689 medical students. And we want to see what are the prevalence of depressive symptoms among our own medical students. This was just published last month in the International Journal of Environmental Research and Public Health. And what we found is the figure is about 17.4% of our medical students have depressive symptoms. Even though the figure seems high, but it's actually much lower, significantly lower than the world average. In meta-analysis study shows that average medical school medical students who have depression is about 28%. Ours is only about 17%. So the range is between 27 to 35%. So in some medical schools, 1/3 of the students are depressed or having depressive symptoms. Among the 17.4%, 0.3 have severe depression, about 8% have moderate depression. So we discussed among our group why our medical students are having lesser depressive symptoms. So we thought probably there's a few reasons. One is because our being a premier university, we teach the students to be more resilient. Secondly, probably the faculty is giving a good support, the academic staff, the curriculum is better, less stressful. And the third reason, we agree that because we have a very good dean. Hopefully with that emphasis, our KPI will be much lower this year. Okay. So major depressive disorder is still, unfortunately, largely untreated. In the study done in the US by Ronald Kessler, in 12 months period, only about 52% are detected by doctors. By doctors, non-psychiatrists, by doctors. So if imagine 100 patients, only about 50% are detected. And out of this 50%, only 22% receive adequate treatment. So a large proportion of patients are still untreated and not detected. So what is depressive disorder? So this is actually a medical illness. It's a chronic medical illness, just like hypertension, just like diabetes, just like arthritis, just like heart disease. It's a chronic disease, but the only difference is that the main symptoms affect the mood, the thought, and some biological symptoms as well. And it is not the same as normal sadness. Okay, everyone should feel sad sometimes in their life. Anybody never feel sad? Please raise up your hand so that my MO can assess you after this. So you never feel sad, that means something wrong with your amygdala or limbic system. You should feel sad and you should feel happy, but you shouldn't feel depressed. Okay, what's the difference then? Normal sadness is experienced by everyone, occurs at certain time only, lasts probably for days or weeks at least, not more than weeks, and it normally will not affect your daily function. But major depression is an illness. It's a medical illness. It is persistent. The sadness persists, lasts for weeks, months, or even years. It goes untreated, and your daily function will be impaired. Your daily function will be impaired, and it's associated with a lot of other symptoms. So what are the associated symptoms? One of the most important symptoms is depressed mood. So patient with depression will feel low, down, sad, depressed almost every day for at least 2 weeks. At least 2 weeks. You have feeling down, low for more than 2 weeks. That's the crucial symptoms that probably you have depression. The second important symptoms is anhedonia, loss of pleasure. You cannot enjoy things you used to enjoy. Let's say going back home after work and mixing with your family. Sometimes you feel joy, right? If you don't, then probably you are having anhedonia. Okay, or having a good meal. Let's say fish head curry. You enjoy it, but anhedonia, you don't enjoy it anymore. Let's say reading a good book or going for a movie, or playing sports. If you lost that enjoyment, easily feel bored, that's another symptoms of depression. Easily feel tired, no energy, very difficult to wake up in the morning. Everything is an effort. Okay, that's also another symptoms. Another common symptoms is painful physical symptoms. Everywhere is aching, headache, muscle ache, back ache. Everywhere is asam, everywhere is angin. So that is the other common physical symptoms. Insomnia, difficulty to fall asleep, or if you fall asleep, you wake up in the middle of the night and you can't sleep again. Or hypersomnia, you sleep more than usual. You sleep more than 12 hours, 13 hours, but still not feel rested, still feel tired. So these are the symptoms. Appetite, you loss of appetite, or you eat more than usual. So loss of appetite, you don't enjoy food. Food is tasteless, leads to loss of weight. Or every time you're stressed, you eat. Not necessarily you enjoy, but this form of to relieve stress. So you keep on eating and eating and eating, and you gain weight and increase in weight. As the symptoms get worse, you started to have poor concentration. You cannot focus. Whatever your boss asks you, your head of department give you instruction, your dean give you instruction, you cannot comprehend what is this instruction, what do I have to do, Or you cannot have a very good conversation. You start to watch movie and you can't understand what is the storyline. You have psychomotor retardation. You feel slow. You feel everything slows down. And later on, you feel worthless. You feel hopeless. Start to feel guilt feelings. And life is not worth living, and better off dead. And finally, you start to have suicidal ideation or even attempting suicide. Okay, so these are the symptoms of major depression. So we had I was involved in this trial, which is sponsored by Lundbeck. This is a multi-center, multi-country cross-sectional study involving countries in China, Taiwan, Thailand, Korea, Singapore, and Malaysia. So you want to see what are the psychiatric symptoms among all these countries. Is there any difference? When I say Malaysia, it's only PPUM. It's not representing actually Malaysia, but because we only take patients from PPUM. And what we saw is the age of onset. Malaysian MY is for Malaysia, CN is China, KR is Korea, TH is Taiwan, Thailand, TW is Taiwan. So what we found is that the mean age is relatively younger in Malaysia. It's about 36 compared to other countries in Asia. But in other countries, the numbers of females who have depression is much higher. But we can roughly calculate. In Malaysia, there's about 30 million or 31 million. And according to the statistical department, 16 million are actually working force. 16 million are eligible to work. So if you take that, studies have shown that if you have depression, you probably lost 1 month of your salary due to impairment, either absent from work or we call presentism. Presentism is quite common. You come to work, but you are not functioning. Just stare at the computer, So depression probably cause 1 month of productivity loss. So we count that the average income of Malaysian is about 1,500 ringgit. So we count 1.6 million times 1,500 ringgit salary. I did the calculation, don't have to calculate your calculator. It's about 2.6 billion ringgit a year. So it's almost equal to the 1 MDB fiasco. Every year we lost. Now I can make this joke. Previously I dare not make this joke. Okay. So you know that depression is associated with disability. It's the second leading cause of disability I've shown earlier. So depression is also associated with severe reduction in quality of life. 60% of patients with depression have severe impairment in quality of life. And the most dangerous complication of depression is suicide. Patients who are depressed have 25 times higher risk of committing suicide compared to the general population. So we did a study on suicide, again, among all these 6 countries, in Malaysia, Taiwan, China, Korea, Thailand, and Singapore. So we survey and we rank patients with low suicidality and high suicidality, and we compare. Okay, so Korea have the highest risk of suicide among all these countries. In fact, Korea now has the highest suicide rate in the world, more than Japan, more than any other countries. So in these studies, 42.6% of depressed patients in Korea are highly suicidal. Followed by Taiwan, 31.3%, China, 21.9%. Even our neighbors just crossed the causeway, Singapore, hardly more than half a kilometer, but the suicide risk is much, much higher, double than Malaysia. And Thailand is not too bad, 10.7%, and Malaysia still at 8.9%. Even though it's lowest among these Asian countries, but we still need to be cautious. We cannot allow it to go up further. And these are the factors associated with suicide. So severity of symptoms, unemployment. So our depressed patients are employed. So with proper treatment, they can go back to employment and can still function. Religion, this is protective. Religion and spirituality have shown to be a protective factor for depression, and social support. So Malaysia probably still have a very good social support. So that's why keep your family, friends together, because it really helps to prevent depression and suicide. So what are the risk factors for depression? I've mentioned earlier, gender, female are twice likely to develop depression than males. Peak age of onset is about 20 to 40. My study shows about 36. Family history, 1.5 times higher. If you have a family history of depression, the risk of you getting depression is 1.5 to 3 times higher. Marital status, you have divorced or separated. Female postpartum, increased risk in the first 6 months. Negative life events, like death of loved ones, financial issue, family breakups, these are all negative life events, increase the risk of depression and serious medical illness. So some of the risk factors we cannot control, like genetic. 35% are genetic factors, but there's also environmental factors, unique environmental factors, which contributes to 65%. And this is a study to show the relationship between genetic factors and stressful life events. Okay, the scientists did check on these genes called 5-HTT genes polymorphism. So all of us can either have what we call SS, short allele, short long allele, or long allele. This one you cannot control. God control that. Give you, okay, Dr. Hazrin, you are short allele. Yeah? Prof. Mustafa, you are long allele. Yeah? So you cannot control. You are given that. So they are exposed to stress. So the first time stressful life event, everybody is the same. There's no difference in risk of depression or suicide. Second stressful life event, still the same. But the fourth and so on is different. So if you are short allele and you always have stressful life events, your risk of depression goes very, very high. In this instance, almost 50% compared to those who have long allele. It's only about 15%. Similarly with suicide. So you have short allele and you're exposed to multiple stressful events, your risk of suicide goes very, very high. So sometimes we cannot control your allele. Definitely you cannot control your allele, and you also cannot control life events. What about serious medical illness? So we did this study in PPM with our academic icons, Prof. C.T. Tan, Prof. K.S. Tan, and Prof. Zuraida. So we identified 114 stroke patients, and we follow up them after between 4 weeks to 8 weeks. And what we found is that the prevalence of post-stroke depression is about 35%, especially associated with left-sided stroke, and especially those who have a lot of disability, significant physical disability. This is a study done by Prof. Ng Chong Guan. He's one of the star lecturer in UMMC. I'm very proud to say that Chong Wan is my student during MBBS, student in the masters, and I was one of the supervisor for his MD, and now he's a professor. Hopefully he can give inaugural lecture soon. So this is his PhD project, and he got 200 cancer patients from UMC. This is various cancer patients, including breast cancer, hematological cancer, GI cancer, and so on. So among all these cancer patients, 35.5% have depression. So 1/3 of cancer patients have depression. So what happens if you don't treat your depression? You just allow it to go on and on and on. So you will have brain atrophy. So actually there's a brain cell loss. Your brain will shrink over time without treatment. So you can see this normal brain, and untreated depression causes atrophy, especially in the hippocampus area. So this is the animation presentation of the theory. So this is the picture of a normal nerve cell with a lot of stress, uncontrolled stress, maladaptive stress, prolonged stress. Your body will secrete a lot of stress hormone, namely glucocorticoids, glutamates, and so on. These are very toxic to your brain cell over a long-term period. And this will eat up your what you call brain-derived neurotrophic factor. So brain-derived neurotrophic factor is a protein in your brain that supports the cell structure. So if you allow this to happen, then your brain cell will start to atrophy and die. And finally, shrinking of your hippocampus area. But that is not the end of the story. If you get treatment, go and see psychiatrists or doctors and get treatment with medication, ECT, psychotherapy, exercise. This will increase other neurotransmitters that will counteract with the glucocorticoids and hopefully increase back your BDNF, and your cell will grow again. So this is again a cartoon representation. Stress leads to glucocorticoids, glutamate. Your cell can slowly die off, but with treatment you can have back the sunshine, or your nerve branch grows back normally again. This is not just a hypothesis, proven by research. So the researcher Shimizu et al. Published in Biological Psychiatry. They take normal control, those who are not depressed. They measure the BDNF, and this is the level. So they take treatment naive patient, that means depressed patient did not receive any treatment, and a significant lower level of BDNF. And they take those who receive treatment with antidepressant, and the BDNF level goes up again. So the theory is proven. Okay, besides losing your brain cell, what else can depression cause? The complication. This again is just published late last year in 2018. Depression is associated with arrhythmia, abnormal heart rhythm, especially atrial fibrillation. So this is a large Danish study. They collected 785,000 sample Danish who are depressed, okay, and compared to the normal population. So before receiving treatment of antidepressant, those depressed Danish people have 7 times higher risk of getting atrial fibrillation. So if you have atrial fibrillation, there's increased risk of getting stroke, increased risk of dying prematurely. So with treatment, 1 month after treatment, the risk of atrial fibrillation drops to only 3 times. And after 1 year of treatment, it normalized to 1.1. So depression can cause atrial fibrillation, and depression predicts the development of coronary artery disease and worsen its prognosis. What about treatment? So how can we treat depression? You can have psychotherapy or talk therapy. You go to the psychiatrist, clinical psychologist, or you can have medication. I'm a psychopharmacologist. I use medication. I don't really do psychotherapy. So I use a lot of medication. If the depression gets more and more, you can use what we call electroconvulsive therapy. So the principles of antidepressant treatment is basically there's a deficiency of all this serotonin, dopamine, noradrenaline, and all antidepressants are aimed at increasing the CNS level of noradrenaline, serotonin, or dopamine. So this is the evolution of antidepressant treatment. The first antidepressant was discovered in 1957, the year that we get independence. Imipramine was first in the market, and later by, is my time up? Okay, so this is a tricyclic antidepressant and also monoamine oxidase inhibitors. These are all antidepressants. They are effective, but there's a lot of side effects. So they come up with a second generation antidepressant, which is much safer, which is SSRI, such as fluoxetine or Prozac, escitalopram. Later, new ones called SNRI, like venlafaxine, desvenlafaxine, duloxetine. And then the NASA group comes in. It's called mirtazapine. Then the melatonin agonist is called agolomelatin or valdoxan. And the latest one is multimodal antidepressant. It's called vortioxetine. So how do we treat? So how do we choose antidepressant? We select based on the previous response. So if patient previously responded well with escitalopram or mirtazapine, then we use that the same medication. We also look at the safety. How safe is the medication for the patient? What are the anticipated side effects? Other general medical condition, and of course the price of the medication. Cost is very important consideration. So based on this criteria, these are the common medication that we use: SSRI, escitalopram, sertraline, SNRI, venlafaxine, duloxetine, desvenlafaxine, NASA, the mirtazapine, the melatonergic agonist, valdoxan, and of course the multimodal antidepressant, vortioxetine. A lot of people are very skeptical about antidepressant. They say, can it work? Can it actually heal, or can the patient recover? Actually, antidepressants are very effective, very effective, and very easy to use. It's easier to treat depression than hypertension or diabetes. You look at the treatment algorithm of diabetes, hypertension. Looking at it, you become depressed. So many branches, but depression is very simple. You give SSRI, SNRI, or all this first line treatment. Is very easy. And those who are familiar with statistic number needed to treat NNT, so depression has a very low NNT. That means lower NNT means more effective treatment. So you look at acute depression compared to placebo, the NNT is about 6, and relapse prevention is between 3 to 6. If compared to aspirin and preventing MI is 40, or statins is 20, which is much higher. Luckily, no cardiologist, otherwise starts, attacking me. How can you say that? Okay. So our antidepressants are effective and safe in elderly patients. So we did this trial supported by Sevier on elderly patients. We want to see whether antidepressants is safe in elderly patients. Elderly means 65 and above. We also have patients up to 85 years old. So we recruited 311 patients in 10 different countries involving about 40 hospitals, mainly in Europe. Asia is only Malaysia and Korea. And we treat for 8 weeks and see in terms of efficacy and safety. And based on this 8 weeks period, there's a robust data to support that antidepressants are safe and very effective for elderly patients. What about patients with treatment-resistant depression? Treatment-resistant means they have failed at least 2 different types of antidepressant. And can we improve? What else can we do? So this is a new novel treatment we call esketamine. Ketamine is actually an anesthetic agent, but esketamine is a nasal spray, and only one of the indication is to treat treatment-resistant depression. So what we did is we enrolled 802 patients across the world with 114 centers, and we give esketamine spray every week or once every 2 weeks for 1 year, and see what the side effects and measure the efficacy. And based on this 1 year data, it shows that esketamine have no serious side effects, and its sustained efficacy can be seen in patients with esketamine. So the next few slides on how to prevent depression. Probably you are not depressed, but how not to become depressed. Okay. So one of the natural way is to exercise. So exercise is the natural remedy for stress. So the key word is regular. Regular. You cannot exercise once a week or once a month or once a year. It has to be at least every other day or 3 times a week. So these are some of my department lecturer MOs. So that's why we rarely see psychiatrists are depressed, because we exercise regularly. This is Prof. Jasjit here, Prof. Rusdi, Prof. Ko, Prof. Eng, even Prof. Amir here. Number 1, he's playing beach football. So we exercise, because every time you exercise, your body will release what we call endorphins. Endorphins is endogenous morphine that leads to feel good. But you can only have sustained level if you exercise regularly. I also see Dr. Hazrin, Prof. Hazrin always exercise, walking to the MRT every day. That's why he's never depressed, I think. Okay. Another important rules to prevent depression, to have a good sleep, good quality sleep. You must get an adequate amount of sleep every night. So different people will have different requirement. Some of you might only need 6 hours, some of you may only need 7 hours, some of you need 8 hours, but you have to fulfill that requirement. So you must establish a regular sleep schedule. So you must use the bedroom properly. You should not put your computer inside, your television inside. Bedroom is only for sleeping, not to play games, not to watch movies. And avoid certain stimulus, especially your handphones, your social media. Please don't tweet in the middle of the night, Don't update your IG, your Snapchat, So put it away and lock it somewhere, okay? And you must also avoid certain foods and drinks, especially caffeine, high-rich in caffeine. Having a protective and supportive relatives or friends are very excellent preventive factors. So person who like to isolate themselves are more vulnerable to problems. So you have friends like Prof. Jasjit and Prof. Eng and Prof. Amir, Dr. Aida, very happy. So you don't feel the depression. So great comfort and relief can be obtained from religion and spirituality. Prayer is good for the soul. It can be remarkably effective for beating up stress. So studies also have shown that you are religious, you're highly spiritual. It protects you from having depressive symptoms. This is also very, very important, and we always do not take notice. Time management. So it's very, very important in managing stress. So this is a very good time management matrix. So you must know what is important in your life and what is not important. And you must distinguish what is urgent and what is non-urgent. So the first thing that you must do is important and urgent. So if I receive a call from Prof. Adiba, that is important and urgent. I must do it immediately. Okay. Some things are important but not urgent. Like your KPI, you still have until December to fulfill. It's important, but it's not urgent. So you probably, after the phone call, I can do my manuscript and my applying for grants. Some things are not important but urgent. Again, your WhatsApp group, your old classmate, let's go for tea, let's go for chat, So you want to reply urgently, but sometimes it's not important, But most people spend their time in the 4th quadrant, which is not urgent and not important, So, example, updating your whereabouts, posting your lunch in your FB, So this I had for lunch just now, So this is the picture of my baby. Unless you are a food reviewer, which is very important to update all your recipe, But if you are a professor in psychiatry, I think it's not important to update your whereabouts, okay? And finally, to have a good break, holiday is a popular alternative that is required in a short term. So in psychiatry, we always have a department retreat where we spend time, we play games just now, we discuss non-academic issues just to relieve some stress. So in summary, depression is a common medical condition. If not detected or treated early, it can lead to substantial disability. Suicide and self-harming behavior are worrying complications. It is a serious but treatable illness. With proper and adequate treatment, patient can recover fully from depression. And my final slides, I'd like to thank all especially my family, my parents, my wife, children, my siblings, my teachers. As you can see, Prof. Boy is my teacher. He is the one who takes me for my final MBBS exam. That's the most stressful part in my life. And thank you to Prof. Boy. He really de-stressed me, and I decided to become psychiatrist. And Prof. Mustafa is also one of my teachers. Okay, thanks to my students, my patients, all the lecturers in FOM, especially the dean, the deputy dean at UMMC, at the department, all the supporting staff, my collaborators, especially from all the pharmaceutical companies, from CIC, from Unit Perundingan, and the organizing committee, especially Nur Zahra. Despite having conjunctivitis and her eyes are swollen, she still comes. Thank you very much, Murni, Syed, Amri, Huzairi, Mazuki, Fiza, Jaidi, Aisha, Nagish, and if I didn't mention your names, please forgive me. And thank you to all of you. With that, I thank you for your attention.
Thank you, Prof. Hatim, for that informative and entertaining lecture. Cuma terasa sikit lah when talking about Instagram and putting on weight. To conclude this lecture, I would like to invite Professor Datuk Dr. Adiba Kamaruzaman again to conclude the lecture that has been delivered by Prof. Hatim.
Thank you very much, Hatim, for that very informative and comprehensive lecture. I think now you know why Hatim is very calm. You can ask him the number of times I actually WhatsApp him. I think if you check your phone, I think in the 4 years that we've overlapped as Dean and Head of Department, it's probably less than a dozen times I've actually WhatsApp him. So that's why he's remained calm. Not so sure about the Deputy Dean, so they probably get a WhatsApp from me every day. As you heard, depression is all around us. Famous people, not so famous people. I think apart from Robin Williams, we were rocked by the death of Anthony Bourdain, and also for the girls in the room, Kate Spade, not more than a year ago. In fact, closer to home, this morning, I was actually woken up very early, before 6, by one of my school teachers, ex-school teachers, who've been trying to help, who's alone, with no family, and sounds like her depression is getting more and more severe. So it is definitely around us, around people we know. Sometimes we, particularly non-psychiatrists, may not pick up the cues, and which may also lead to the delay in presentation that you heard is from Hatim's and his colleagues' studies that is common in Malaysia. I think it's not just depression and mental illness. Malaysians tend to present late, but it's throughout most diseases. But in depression, as you heard, something that is relatively easily treatable. We ourselves need to be aware of the people around us, and if they manifest any of the symptoms and signs that Hatim shared with us, offer them treatment. One problem, which I guess you didn't have the time to touch on, is the incredible stigma that people, not just mental health in general, suffer from in this country, but in even depression, let alone the more florid psychiatric illness such as schizophrenia and others. But even depression generates a lot of stigma, and I think that's part of the problem that might lead to late presentation for help. What is very comforting to know is the relatively low prevalence amongst our medical students. I don't take credit for it because actually the new curriculum is even more demanding on the students. But I guess the resilience may come from the spirituality and religiosity. I did wonder when I first came back to Malaysia. I observed that we were not seeing as many, let's say, amitriptyline and the likes, overdoses that I used to see very frequently as a medical registrar in Australia. And I think that has to do with the lower prevalence and the more resilience and the in general, religiosity and spirituality, and I guess for us Muslims in particular, it's such a big taboo that that most people probably would not even, or most Muslims would not even go there in terms of contemplating suicide. So Prof. Hatim ended with a lovely menu of things to do to prevent from getting depressed, and actually they're all very, very doable. Of course, exercise, most people say, we don't have time. Most academic staff in the faculty will say we don't have time for it, Prof. How to exercise? You make us write papers and publish and get KPIs. But exercise can come in many ways. Those four flights of stairs. It's just there. A few courses of those stairs already constitute as exercise. Sleeping, yes. I think recent research says that we all need a minimum of 7 to 8 hours sleep. So even if you think you can get by 6 hours, it's not enough. Perhaps not as a prevention. Perhaps it may be enough as prevention for depression, but 8 hours is what we need so we don't die early of myocardial infarct. Again, how do you do that when you have to publish 2 ISI papers a year? And the key, as we heard, is in time management. Don't entertain those WhatsApps that don't need to be replied urgently, and self-promotion on Instagram and all that may not be so important. So I'm sure all of you would agree that that was a really wonderful lecture interspersed with personal anecdotes and so forth. Some of you in the room would have heard me say this many times. I firmly believe, with apologies to my other colleagues in other specialties, that there are only 3 real specialties in medicine. There's infectious diseases, there's endocrinology, and then there's psychiatry. Because if you think about it, most diseases can be explained by these 3 things, germs, bugs. Many cancers are caused by infectious diseases. Endocrinology, the hormonal imbalance gives rise to many diseases that are often unexplained. And then you've got, the mental illness. But other than that, I think most other diseases can be explained by these 3 major diseases. So, as I said, I preface that with apologies to my colleagues in other specialties as well. So with that, I've always admired colleagues who choose to be psychiatrists because it's not an easy specialty. You don't have MRIs to help you diagnose. You can exclude things by MRI, but you can't confirm bipolar disorders by MRIs. And often the patients can be very difficult to manage, but I think on the flip side is you get immense satisfaction from seeing someone having a truly chaotic life, and that can be really life-changing just with the proper and appropriate treatment. So Congratulations once again, Hatim, and to you and your family. Thank you.
Thank you, Prof. Adiba. Thank you, Professor Dr. Adiba Kamaruzaman, for chairing this lecture. I would like to take this opportunity to thank the management of the Faculty of Medicine, as well as the guests for participating in this event. With this, we have reached the end of the lecture, but before we leave, we would like to take a moment for a photo session.